Hello, everyone. Thank you for joining today's webinar. We're going to give folks a few moments to get logged in. And while we wait, I invite you to answer our opening question, which is, where are you calling from? I am calling from Detroit, Michigan. For the folks that recently joined us, my name is Janelle, and we are just giving folks a couple more minutes to join. If you would like to, please share in the chat where you're calling in from. I'm calling in from Detroit, Michigan. Awesome. Please continue to share in the chat. We invite you to use this feature throughout our time together today, and we're about to get started. We are made aware that there was some challenges with the chat, so I believe it's been fixed. But welcome to today's webinar, Communities That Care, Justice for Black Moms. My name is Janelle Munger, and I will be your host for today's conversation. I am the owner of GPM Consulting and a program consultant with Keisha Harris and Associates Race Healing and Joy Initiative. Our conversation today is co-convened by Oxfam's A New Era for Black Women and Keisha Harris and Associates Race Healing and Joy Initiative. This is the first entry in our Black Futures webinar series, a four-part conversation that uplifts the expertise and vision of Black women, shaping the future through reproductive and care justice, economic mobility, environmental justice, and democracy. Keisha Harris and Associates is a Black woman-owned social impact consulting firm. KHA operates the Race Healing and Joy Initiative, which works to center the voices of Black leaders in the reproductive justice movement and cultivate deeper, unrestricted investments in reproductive justice organizations and their leaders. Oxfam is a global nonprofit committed to fighting the inequality of poverty, and Oxfam's New Era for Black Women initiative, launched in 2023, takes a comprehensive approach to uplifting and empowering Black women. The initiative highlights the structural barriers and economic disparities that have created generational limitations, intersecting all aspects of quality of life for Black women. For more information about each of these initiatives, opt into our mailing list when you complete the survey. Today's conversation, Communities That Care, Justice for Black Moms, centers the needs to lift up the care for birthing parents throughout pregnancy, labor and delivery, and postpartum. Using a care lens, we hope to show that reproductive justice is always a care issue. Care is a societal need, but often viewed as an individual responsibility. In the U.S. Today's conversation will highlight how and why that is wrong, but ways they are actively challenging that in their work. Our panelists will walk us through a conversation that daylights present realities and disparities for Black birthing parents, uplifts interventions and practices for better care, centers the role of collaboration and partnership in creating change, and underscores the importance of investing in infrastructure for reproductive care and justice. To facilitate our conversation, we are joined by Danielle Adams, the Senior Advocacy Advisor for Oxfam America. In her work, Danielle sits on the organizing and influencing team in the campaigns department, working with grass top leaders. Now, please welcome Danielle and our panelists. Oh, Danielle, you're still muted.
I thought I did the work to do that. Good morning, everyone. Thank you for that introduction. And thank you to our panelists. I'm so pleased to be here with you today, moderating this panel of powerhouse Black women in their respective fields. Our panelists, who you will meet in a moment, are Nikitra Burse, doctor, a PhD in public health and maternal health expert, Dr. Veronica Gillespie-Bell, an OBGYN and medical director of the Louisiana Perinatal Quality Collaborative and Pregnancy-Associated Mortality Review for the Louisiana Department of Health. Tamara Mason, Director of Maternal and Child Health Collective Impact at March of Dimes and a certified labor doula. And Tanisha Duncan, founder and CEO of Orchid Capital Collective. Dr. Nikitra Burse, I would love to start with you. I'd like for you to help us ground in the issue postpartum care for Black birthing parents and why this is an important conversation for all of us. My question is, what are the current realities and challenges faced by Black birthing parents in accessing quality postpartum care, and how do these conditions reflect broader systemic inequality?
Yeah, well, good morning. It's good morning in Mississippi. Everywhere else, it may be good afternoon. First, thank you all for having us. I'm excited to join this panel. And thinking about grounding in the thought of what the issues are and what Black women face, I think the big picture is, of course, access to care. And so we are now moving into this phase, and I know Dr. Gillespie-Bell may talk about that postpartum period being the fourth trimester, but many of us are just moving into that piece of recognizing the postpartum period as an area that really needs to be looked at, studied, and a lot of attention given to. And I think that's just because of how it has been framed. You know, you have this baby, you go home and everything is good. But that's not necessarily the case for every woman, specifically Black women. So access to postpartum care, what does that look like? That looks like having access to health insurance. Health insurance covers one piece of that. But then if you are living in an area, I'm in Mississippi, we're a rural state. And so many of our areas are hard to access, whether that's if you live in the Mississippi Delta where you don't have a lot of providers, then you may have to drive 2 hours, an hour and a half to get to any type of quality services. And even in that case, when we look at that postpartum period, if something like postpartum preeclampsia happens where you need to get to a facility, if you're in an area like the Mississippi Delta, you may not make it to where you need to go because hospitals have closed, and your place may be 2 hours away. And that is a critical thing that we're seeing. Not expanding Medicaid in Mississippi has been very detrimental, not just to the health of Black mothers, but also to the type of care that women can receive. We've we've had NICU units closed, so many things. And we've even had cases that have made the news of women trying to get to care, but they had to drive so far, did not have a hospital in their area. And then another thing is access to, or really bringing in this model of comprehensive care and what that looks like. So we, of course, we have doulas. Ms. Mason, I know you'll probably talk about doulas' role, but doulas, midwives, and having access to just this range of types of care that you would like to have we don't have that. Black women just don't always have that privilege to say, okay, I want a doula, I want a lactation professional, I want to have a birth in a birthing center. There are a lot of things that we just may not have access to because of our position in society right now, just being honest. And so I think having a comprehensive care team or a model that supports doulas being able to come into the hospital and or just having a range of midwives that folks can select from is important. And then also, I'm not a healthcare provider, but we do know that chronic illness is a part of all of this. And when we say chronic illness being a part of it, these comorbidities, I take the onus off of Black women and I put it on the system. And so my last piece to this is racism being the core of all of this. Not just those one-to-one interactions where they didn't feel good and we didn't have an opportunity to change providers, which is a huge piece of it, but how this system was created, developed, and how we have to navigate it. I always say we have amazing healthcare providers. I know Dr. Gillespie Bell, I've heard of your work. And so many other providers that we have in Mississippi, but you can only do so much in the system that was not designed to honor Black bodies. And so I think that is the core of what we're up against, and that trickles down into the way we seek and receive health care, specifically in that postpartum period. And that superwoman cape, you know, we're going to take care of that baby, we're going to take care of those babies, but if our head is swimming, it may be harder for us to go try to seek the care that we need. And one advantage that I think we have as I close out this is I think we have a great advantage of we do have the communal system of support. Black women, we are, I was raised in all kind of woman's family, so everybody kind of takes care of you. Now that may not look the same way, but I think that is a piece that we can kind of build from, building on that communal system of care and what that looks like for each woman. And we don't always have all of those pieces that I've mentioned pulled together for Black women. And then we see these very grim outcomes that we're all working to change.
Thank you so much for that answer. One of those folks who did have postpartum preeclampsia, but I did have the privilege of a care team and the privilege to advocate for myself and to have folks advocate for me, which brings me to you, Dr. Gillespie Bell. I'd like for you to give us more information to understand how the system presently works at its best and worst. I know the state of Louisiana can be challenging to a place to provide comprehensive care for Black birthing people. So my question is, what does it look like to provide robust care against the backdrop of these challenges? And what steps can be taken to ensure care for Black parents after birth is accessible and integrated into maternal care practices?
So thank you so much, Danielle, for that question. Thank you for allowing me to be here. Thank you, Oxfam and the Keisha Harris Association for even hosting this. Just important things that we need to talk about. Just to piggyback on some things that Nikitra said, we have to understand that a system will produce exactly what a system is supposed to produce. And right now I'm about dismantling systems because this system is not working. It's not working for any woman in America, and it really is not working for Black women. We know that we have the highest maternal mortality in the United States compared to any other high income country. We know that 3 Black women die at a rate of every 1 white woman. We know even when we adjust for socioeconomic factors, that a Black woman is twice as likely as a Black woman with a college degree is twice as likely as a white woman with an 8th grade education to experience a pregnancy-related death. So this is a system that is not working. We're not getting good maternal outcomes. And so when we think about what is not working in the system, and we can talk about what is working, but when we think about what is not working, specifically for Black women and specifically in the postpartum period, which I think is, as Nikitra said, is so important for us to talk about, because when we look at our maternal deaths, the majority of deaths are not happening in the hospital. They're happening after discharge, up to 1 year postpartum, with the majority of those happening in the first 6 weeks. And as Nikitra said, if we think about the system is designed for us to deliver our babies, and then we go home and we come back in 6 weeks for this arbitrary postpartum appointment, when clearly there's a lot of things that are happening in that 6-week time period. So really, when we think about solutions, we need to think about how do we make sure our patients are connected to care in that 6-week time period. And so that, again, is dismantling the system, because that's not how the system is designed. Some things that we have done in Louisiana, some things that are being done nationally, and some things that we need to think about. One is postpartum home visits. We, again, are the only high-income country that does not guarantee at least one postpartum home visit. We have to think about how do we provide that. Here in Louisiana, we do have the Nurse Family Partnership Program, which is a national program, which is it works well for the patients that qualify for the Nurse Family Partnership Program. We also have a program that we're piloting specifically in New Orleans at 2 hospitals called Family Connects, where a nurse from the hospital will come and see patients during that postpartum period. But overall, we are piecing things together in every state to try to create what should be a universal home visiting program. I think one of the other things that we have seen, specifically in my role at Ochsner to help with that postpartum period, is to do telehealth. So with our program, it's called Connected Mom. We give patients a blood pressure cuff, a Bluetooth-enabled blood pressure cuff at the beginning of pregnancy. We offer it to any patient that wants to be in the program. They don't have to pay anything for it. We're able to check blood pressures throughout the pregnancy, but more importantly, we're able to check blood pressures in the postpartum period. So it gives the patients autonomy, because when they check their blood pressure, if it's elevated, the patient gets a message that says, hey, your blood pressure is elevated. Take it again. If it's still elevated, you need to call your doctor, go to the emergency room. I, on the physician end, I also get a message telling me that patient's blood pressure is elevated. The other part is that we're able to do virtual visits through this program, much like I'm coming to you today doing this panel presentation. And so when we do that, I'm able to do blood pressure checks for my patients 3 days after discharge from the hospital if they had severe hypertension. I'm able to do a blood pressure check 1 week if they had a hypertensive disorder of pregnancy but didn't have severe hypertension. And during that 1 week or 2 week time period, I'm able to do a postpartum mood check, in which we don't talk about enough, especially in the Black community. We don't talk about it, but actually when we look at our leading cause across 38 maternal mortality review committees, mental health conditions is actually our leading cause of pregnancy-related deaths in the US. And so we're able to check those blood pressures, able to check those mood checks while the patient is able to stay in the comfort of her own home. I think the other part of the system that we need to address, and Nikitra was talking about it as well, is postpartum visits from doulas as well as midwives. When we think again about the system, our data shows us that by 2030, that's in 6 years, we will be short 5,000 OBGYNs in the United States. 5,000. I think that number is actually underestimated, because we're seeing even fewer medical students choose to go into OBGYN. So I think that those numbers are probably going to be much larger. And so we have to think how we have an integrated model of care where we can have our midwives that are able to take care of our low-risk patients. I, as an OBGYN, can take care of my high-risk patients. And then we have a doula that is helping our patients to navigate the healthcare system during pregnancy and after pregnancy, so that you have that person that's able to say, hey, that blood pressure is not okay, or that headache that you're having, you need to go to the hospital to be evaluated, or you're not acting like yourself, something's not right, you need to go to the hospital. And I think doulas and midwives, because they are able to spend so much more time with their patients, compared to what we are able to do as OBGYNs. They have such better relationships to understand those intricacies of when something is not quite right. And so again, just thinking about how we keep our patients connected to care. Now, some things that we are doing in Louisiana to help with that, I mentioned the home visiting program. I mentioned the connected health program. We also have passed legislation to create a doula registry. This is completely run by doulas. They have come up with the criteria to be in the registry, the application process. Once doulas are in the registry, there's other legislation that we passed that then requires insurance companies to reimburse for doula coverage. Again, we know the data shows that when doulas, midwives are involved in our pregnancies and delivery care during the prenatal and postpartum period, we have better outcomes. But everybody is not able to access a doula. One, just the number of doulas, but also when it comes to how they are able to pay for them. Some of the patients that need doulas the most are not able to access them, and so we're hoping that this will create some more equitable access to doulas. I talked about telehealth and the benefit there, but it doesn't benefit you if you're in an area that has no broadband access. And so there has been a lot of work in Louisiana under our previous governor to expand our broadband access. We're not where we need to be, but we're better than where we were. I actually was at the FCC speaking last week. The FCC has a broadband map that I encourage all of you to go look at. You can see by county what your access is to broadband, and you can see how that relates to maternal mortality, to maternal morbidity, to diabetes, to all of those things. And so the FCC has said, and I definitely agree with this and promote that broadband access is another social determinant of health. So the solutions that we're coming up with, if we don't think about it through a lens of equity, it's not going to be a solution for everyone. And so I'm glad to see again that the FCC is showing that so that other states can really invest in the broadband access as we have in Louisiana to be able to make sure that our patients have access there. And then I guess the final thing I would say in terms of what we're doing in Louisiana, we know that, and this is a conversation we were having, actually, Danielle, you and I were having before the panel started. The data shows that when you have concordance of race between the patient and the provider, you have better outcomes. We've seen that from the work that Rachel Hardiman has done in California that showed, in Florida, that showed when the neonatologist and the infant and their family were the same race, that we had lower infant mortality. We've seen that in primary care work and with primary care physicians. When you have a Black primary care physician, you have a longer life expectancy as a Black patient. But only 5% of physicians identify as Black, 5.7% to be specific, 6% identify as Hispanic. And then when we look at our residency programs, the distribution of, as far as race and ethnicity is not any different. So we are not creating a better pipeline to have diversity amongst physicians. We are trying to solve that. At Ochsner and Xavier have partnered together to create the Xavier Ochsner College of Medicine. We're currently doing all the processes that we need to do to be accredited, but we are doing this and making this collaboration so that we can have more Black and brown physicians coming through and trying to increase that pipeline so that we can have better representation amongst the physician population. And I can go on and on and on, but I don't want to monopolize the time. So I think I answered the question.
No, thank you so much. You dropped so many words and so much information I didn't even know. And hopefully it resonated with the folks who are joining us to listen in. And I think it connects beautifully to our next guest, Tamara Mason. We have heard a bit, and first I want to give all of you your flowers. Thank you for being a Black OBGYN. Thank you for being all of you in the healthcare profession and taking care of women. And I will say a Black midwife and a Black doula saved my life. So I'm excited for this whole panel and this conversation. Ms. Mason, we've heard a bit about the realities and importance of this care. We also know that for the changes we seek to happen, it's going to take co-conspirators across sectors. And from this lens of your work with collective impact, an approach to bringing diverse organizations together to work on systems change. I'd like for you to speak more about what this collaboration looks like and how it happens. Specifically, how can different sectors, such as healthcare, community organizations and activists, policy advocates, funders, collaborate more effectively to improve care for Black birthing parents?
Thank you, Danielle. Thank you so much for having me, and thank you to Oxfam and KHA Associates. First of all, who wants to speak after Dr. Gillespie Bell, right? I'm like, I'm just going to go ahead and sit down. She said everything that needs to be said. But as Danielle said in my introduction, I work at the March of Dimes as the Director of Maternal and Child Health Collective Impact, specifically in Atlanta, Georgia. So at the March of Dimes, we're leading the fight for the health of all moms and babies, and we are working to end preventable maternal deaths and infant deaths. And more importantly, which I appreciate this about March of Dimes' mission in recent years, we're working to close the health equity gap. So definitely appreciate Dr. Bursa's comments and Dr. Gillespie Bell's comments previously in terms of access to care and framing the issue and our system, right? Our healthcare system that honestly has been designed to not really care for Black bodies, Black birthing families. And I did want to mention in terms of access to care, the March of Dimes, we recently released a maternity care desert report where we show that unfortunately accessing healthcare is an issue for everyone in this country, but particularly for our communities of color. And in particular, in terms of maternity care deserts, which that means that there are no OBGYN centers or birthing centers, 35% of the counties in our country are considered maternity care deserts. And about 60% of those counties are rural. So just in general, as we've already heard in the conversation, just getting that general access to care is a huge issue in our country. So from preconception health, right, before you're even thinking about a baby or starting to think about having a baby, all the way to postpartum care. So just nationally, that's a conversation that we need to engage in more and figure out within our communities, how can we address the actual getting the access to the care that you need. Secondly, I really appreciated Dr. Bursa's comments about the system and how the system is not designed to care for us. And so at March of Dimes, when we're talking about closing the health equity gap and addressing a large scale issue like maternal death, infant deaths, preterm birth, we realize and understand no one organization, including us, can do this work alone. And so that's why we are utilizing the collective impact approach in Atlanta and throughout other cities in the country to really address this large scale issue. We also know pregnant women don't live in a vacuum, right? So if a woman is food insecure, if she's housing insecure, if she's poor, which here in Atlanta, if you are born into poverty, you only have a 4% chance of escaping poverty. And there are a large number of women of reproductive age who are in poverty, right? All of that is going to impact your birthing journey. So in addition to working with our maternal and child health providers, we also have to work with our folks across those other systems and all the other partners that you mentioned, Danielle, in your initial question. And so here in Atlanta, we're really proud that for the past 3 years, we've been leading this collective impact initiative, working with, as you said, funders, community-based organizations. One of our main partners is the Center for Black Women's Wellness. Love them. I shout them out every chance that I can get. They are in the Mechanicsville community of Atlanta doing great work serving Black moms and families for the past 30 years. And just really coming together as a collective to first understand the problems for Black birthing people here in Atlanta, but not just stopping there and talking about the challenges, the problems, and the issues. What are our solutions? And so with collective impact, we really feel, because we are at the end of the day about system change, we have to address different levers and pull different levers of the system. So that includes research, that includes advocacy, that includes direct service programs. And so when we are talking about the different levers that we need to pull to close the health equity gap, also looking at who needs to be at the table to be involved in those conversations, including the community. Because in my opinion, the solutions are already in the community, and we have to stop talking at the community, and the community needs to be at the table from the get-go. I'll stop there, but definitely can go on, but want to leave time for other folks as well.
Thank you so much for that. Thank you. Our final question to our panelists before we go to our question and answer is to Ms. Tanisha Duncan. You offer a unique perspective on this topic with your work to seed investment in reproductive care infrastructure, ensuring capital is available for ecosystem changes and needs, and you play a key role in shoring up resources for this work. I'm wondering what strategies can be employed to strengthen the ecosystem of care for birthing parents, ensuring adequate resources are available. Sturdy infrastructure is in place, which we've heard is like a critical need, and the community served, and that communities are served, driving forward this change.
Yeah, good afternoon. Thank you so much for having me today. This is a great question, and it's often one that I start with a few frames before jumping into the strategy pieces. And so a lot of people have talked about these other elements here. And at Orchid, we are a nonprofit impact investing firm. Our work is about redirecting the flow of capital to realize reproductive and economic justice. And so when we start with reproductive justice as a framework and a strategy, it encompasses our rights to decide how our families are created and nurtured, how we make decisions about our reproduction, and how our communities are actually structured to live in and raise families. This right to raise a family in a safe and healthy environment. And so for this to exist, we have to ask what makes a community safe and healthy? How would we actually invest in that? How do you design the infrastructure of a community? What would we implement? And who leads, designs, and benefits from it? The next frame would be about racial capitalism, which asks us to question where divestment and extraction has taken place. We can note this in the history of how we removed midwifery care from the healthcare system. What assets do we have that are actually not being resourced, and why? And what are the barriers to moving this forward? And who is sitting or not sitting in a place of power? The next is that this place where we, I think, need to talk a lot more about the interplay of the economic system with our care systems. There are a lot of moving parts to this, and often these conversations come down to money. And so we have to really look at this business of healthcare, the business of birth, and who gets to have what outcomes and at what cost. Then there's this place around collective care that asks us to consider everyone's wellness. And if we're doing this, we build from a place of how we want to see people enter and leave this world, and what they experience in the meantime. So how do we shift to actually create a genuine culture of care, balancing the reality of trauma to build a new and different future? And then complex adaptive systems ask us to consider, how do we know when a system has fallen apart or is falling apart? And like someone mentioned earlier, it's when people are being irreparably harmed because of the system. So this current system, in a lot of ways, it's on its way out. We're dismantling so much here. It's a question of when will this happen? And I think we're actually nearing that moment. So we all are collectively having to doula this transition into something more restorative. So the question, what are the strategies that can be implemented? At Orchid, we talk a lot about this ecosystem of care. We define it or call it a community care infrastructure, which is the assets, the providers, the care models that ensure access to culturally and racially congruent care, safety, rights, education, and economic power. So this actually just starts with even acknowledging the value of an ecosystem. One approach is not going to work, right? It's not about seeing one model or one organization do everything and scale everywhere, but actually enabling the resourcing that ensures caregivers and care organizations can excel in their place in an ecosystem, and then really mindfully integrate with other parts of the ecosystem in order to serve families most effectively. The next strategy or approach is actually about exploring all of our collective relationships with money, with financial and non-financial resources, and how that allows us or doesn't allow us to center economic mobility and wellness in the work. Change takes time, love, and more than just money. That's something we are learning a lot about at Orchid. And so it's inviting people to see money as a tool, along with support resources and strategic partnerships and care to ensure that these shifts take place. And so with that, we explore, and we think we can explore different approaches to grant making, to lending, to investing, and especially how we use philanthropic and public dollars to support care ecosystems away from a relationship of dependency and towards self-determination. Building on that, economic mobility encourages us to understand and consider the ownership of the structures being built. So the infrastructure that we can build can stabilize families, create local jobs, improve healthcare outcomes. And there is a way for this to be owned and led by the communities that it serves. And actually, that is the strategy. That's the imperative, is that any funding strategy, any investment strategy, and I say investment a little bit loosely because I think that can happen at the city, state, federal, public, private level. Any investment system has to include community ownership, and that allows it to actually mindfully integrate with the system around it and hold its power while it connects in and works with the system that we have. This is an investment in owners, in accountability, in building longevity, and in community wealth. We look at that through 3 lenses of community care centers, where we think land and real estate is a reproductive justice issue. Community care ecosystems, so growing, nurturing, and maintaining the workforce of perinatal care providers. And then tech and services, like Dr. Gillespie-Bell mentioned, we need to activate and invest in the tech, the range of services, these things that enable care access as well. The 4th strategy is taking a multi-generational approach. So from wherever you sit in the ecosystem, as a funder, we see these investments as seeding a new future, one we may not get to see ourselves. And so when we operate from that lens of a long-term reparative, regenerative approach, it means that we make different decisions, we iterate early and often, and mistakes are actually part of the design. It changes this narrative of how we must be perfect in every program or project that we do, but actually this could allow communities to continually design based on the inevitable political, economic, and cultural shifts. So it's a path to a delicate balance between patience and urgency, and understanding that the work ahead is both vital and time sensitive. So I think the gaps are clear, the data is clear, how we support families, how we invest in this work. As many RJ leaders have said, fund us like you want us to win. And that's the approach that we take at Orchid. We've seen that people are midwives, doulas, perinatal care providers. This community work, it's working. The proof is there. We're delivering better outcomes. People are asking for this care and experience. So really the main strategy is to take action. And I think these 4 points are just a starting point to also push us to think about how we do the work as being just as vital as what we do.
Thank you so much. I love that. Fund us like you want us to win. And I love the concept of like ownership, community ownership of our care infrastructure and our needs. I'm so grateful to all of you for being disruptors and dismantling the systems that we know do not work for us. And thank you for sharing all of your knowledge and information with us. I want to open it up to our guests, our attendees, who, if there are any questions from the folks who are in the audience. If you have a question for our panelists, please write it in the chat, or use the Q&A, or use the hand raise button, and you will be unmuted when you're acknowledged to ask your question to the panel. And I'm seeing there were some questions that were already answered in the Q&A. Are there any questions from any of the folks in the audience? And if I am missing any, hopefully someone will ping me so I can make sure that I don't leave anyone.
Marwa, if you are unmuted, so you can ask your question.
Thank you very much for caring for the vulnerable and marginalized women. I have one question regarding the funding organizations. As you see, there is evidence pointing toward the less care provided to women from the minority group. And the question is, if we have all the evidence and all the research studies that supporting that, do we have an organization or programs to support a community, like maybe businesses, like say if a group like your group right now decided that they want to start a woman health center for just caring for the underserved community, if there is any program or funding programs in the government that we can maybe write a business plan and submit our plan and then start from there. That's all. Thank you.
I'll jump in a little bit there. I'm sure others can add. I think we're starting to see more and more funding opportunities here. I know in the proposal around the Momnibus, there is proposal and allocation of resources in order to fund health centers, birth centers, and community care centers. That's part of the work, but it's not widespread quite yet. And that Momnibus legislation has not gone through at a federal level. However, we are seeing that some legislation is being passed in particular states. So Massachusetts, the birth center there that's developing just got helped to push through legislation for allocation for money for birth centers in the state, and other states are following suit. So I think it's happening more at a local level and not necessarily at the federal level quite yet. And then on the philanthropic side, there are some funders funding this work. There are groups like Birth Center Equity, which is a national network of about 40 Black, Indigenous, and people of color-led birth centers. That is both a network, and they're providing seed funding for organizations like that. We work with them very closely. And then there are individual funders and impact investors and others who are moving resources in that way. But no, there's not just one collective organization. And then there's also the venture capital side of things where folks are receiving resources to build there, but that's not necessarily targeting lower income people and families in communities. That's more of a commercial or larger scale approach.
And just to piggyback on what Tanisha said, you may want to partner or to check with your state health department. I know we just received the Maternal Health Initiative grant, which it was required that state health departments apply for it. But as part of that grant, we have to have a maternal health task force that's designed by that is organized and led by community birth advocates and those individuals in the community-based organizations. And so we're thankful to get that reward, and we're currently developing the team of the maternal health task force, because then that's going to lead to recommendations and implementation of other strategies and other programs. Also, CMS has a TEMA grant. I forgot what that stands for. Transformation in Maternal Health, I think is what it stands for. Applications just had to be submitted. They're going to award 15 states. In this grant, under that grant, the states do have to do a number of things, including addressing the midwifery gap and how to incorporate midwives into practice, how to promote birth centers as well, and remove barriers around that. And so there are some things out there. Oh, I'm sorry. And the CDC also had a grant where it could be tech companies, community-based organizations had to partner with perinatal quality collaboratives. So I know myself, Tennessee, and Illinois all worked with the Earth app to create an initiative as well through that funding. So there is some federal funding out there, but from what I have seen, a lot of the federal funding has to go through the State Department, because Medicaid or the State Department has to be the one that's actually applying for the grant.
Thank you very much. I appreciate.
And I'll add one thing, what we're seeing with folks is that there's benefit, and it's a necessity to actually get resources from a lot of multiple sources. Having one place and a dependency actually doesn't create sustainability for the organization. So people are, depending on revenue from care, whether that's, private or public insurance, then they're getting resources from maybe more traditional or local community banking in order to purchase a building or do those sorts of things. So the money has to come from multiple sources. And that's part of the work that we do with partners, is to make sure that they're looking at all of the options in order for this work to continue, especially because they're prioritizing families who are eligible for Medicaid to access care.
Thank you very much. I appreciate it.
Thank you for your question. We do have time for maybe one more question from the audience. But while we wait for you all to formulate the question, I wanted to ask our panelists, we know that we're coming up an important time, and a lot is at stake as we move forward. And I think there's opportunities for us to talk about, as you all talked about, the comprehensive care, but things like paid leave, long-term and home care. I know many of us are in that sandwich generation where we're caring for littles, planning our families, and also caring for the older generation. And a lot of that care burden and stress falls heavily, especially on Black women. And I'm wondering if you could talk to us about like the totality of what's at stake and what we should be prepared for moving forward in the next few months and years ahead.
I guess I can start and try not to get emotional in the meantime. I mean, everything is at stake. Everything is at stake. There are things that may not be on your radar that will impact how you are able to be cared for, what decisions you're able to make about your care, what access you have, what resources you have. So I think it's really important that when you are going behind that curtain to vote, that you consider all of those things. Move past the rhetoric, move past what's been said in campaign ads and all these other things, but really understand the decisions that are the individuals that are running for office, the decisions that they have made in the past, what they say they're going to, those decisions that they're going to make in the future, because it really does impact everything. And I feel almost as a Black community, I hope I don't get in too much trouble for saying this. I feel almost as a Black community, we have been lulled to sleep. So many things have changed so small and so incrementally that we're going to wake up in 5 years and we're not going to have the right to vote. We're not going to have the right to choose who our providers are, any of those things, because our rights are slowly being taken away from not just thinking about the national election, but even our state and local government. When there are things, again, that decisions that are made, they impact us in such a way, even around reproductive rights. When it doesn't matter where you stand on the abortion issue, if you're for abortion, you're against abortion, whatever that is, you have to understand the ramification of the Dobbs decision and what that has meant downstream, those unintended consequences. I mentioned one earlier, that when we look at since the Dobbs decision, when we look at physicians and medical students choosing where they're going to go into residency, the states that have the strictest abortion bans have had a decreased number of medical students applying for residency in those states. Well, the other part of that is that lots of physicians that are practicing in an area choose that area because that's where they trained. I'm not from New Orleans. I'm actually, Nikitra, I'm from Mississippi. I'm from Meridian, Mississippi, but I trained in New Orleans. And so I chose to stay in New Orleans. So if you don't have medical students that are coming to train and do residency in your state, you will have an overall decrease of physicians. And so that's just one small example, but just understand that small decision that may seem so small has such a greater impact, even if that consequence is unintended.
Okay, can I come in? Quick. Yes, that's like workforce things. Every time I hear the conversation around, the Dobbs decision, Roe being overturned, this is one policy that we immediately see the impacts of. And typically, like those of us that live in this nonprofit world, we understand that administration ebbs and flows. So, when have a Democratic administration, most of the work that we're doing, there's funding out there. And then when it's a little more conservative on the Republican side, and this, I'm speaking for myself, so I don't have any, body pulling my coattail. So then we know that some of those funding dries up. We saw it in HIV. We see it over and over in these 4-year cycles. And so those of us that kind of live in this space are able to kind of prepare, depending on what we expect for administration to potentially look like. The preparation now is not as subtle as we have typically looked at. It is not just the financial impact to our organizations, but it's the direct impact to the people that we serve and what it looks like when we go behind that booth and put someone in office that continues to double down on the things that we talk about. These pieces of racism, when we are talking about, we talk about these one-to-one instances, but this is much bigger. It's the systems that Dr. Gillespie Bell talked about, dismantling them. Being able to dismantle them is lifelong work, and it will be even harder. That's what's at stake. Yesterday, y'all know that Facebook is a never land of of political pundits. And someone said to me, abortion is not on the ballot. I don't even do this. I don't even talk to people on Facebook about politics, but someone said abortion is not on the ballot. That's a big talking point for people, but it's reproductive health rights and justice. It's all of our health care in this big umbrella that's actually on the ballot. And if we go down a rabbit hole of abortion care, which is actually a part of reproductive health care, then that gets people off their rocker. All of our health is at stake, everyone's health. And so I think it is so important that we continue to, we only have a couple of weeks left, but our communities have to understand, and it's our responsibility, those that we're sitting on here talking amongst the choir. But what's really important is those people that we serve on a day-to-day basis. Yes, everyone has the opportunity to choose what they want to do when they go behind that voting booth, but it's our opportunity to tell what we know and what we see from this perspective. Rant over, sorry.
No, thank you for that. I think you're right. We may be speaking to the choir, but I heard someone say once, well, we need the choir to sing. So I think as we come to close, I would like to give you all an opportunity to share one last thought or vision or moment of action for our audience that we can take forward with us on this important topic. I know where my one action is, but I would love to hear from all of you, starting with Tanisha.
Yeah, I'll echo what other people have said, that what we're up against and what's coming is really, to me, zooms all the way up to just being an issue around bodily autonomy and sovereignty, which is everyone's issue. And when they come for one of us, they come for all of us, which I think requires us, my moment of action or my ask of people is, where figure out where you sit in the ecosystem, and let's please all be reaching out to each other across the ecosystem, because our work is deeply interconnected and we don't exist without the rest of the people on this screen, and that we don't exist without the people who are here joining us in this webinar as well. So build relationships, grow your ecosystems, and invest in that from where you are and from where you can.
Thank you. Tamara?
I had a feeling you were going to call on me, and my comments dovetail with Tanisha's. So always going to echo, we know that we have a very important election coming up, voting, but not just in the national elections, our local elections, right? Because at the end of the day, we're in our local community and underground, that impacts us many times, much more so what's coming down, from the federal pipeline. So just want to put that out there, like everyone else has already done. But also piggybacking on Tanisha's comments, I think for me, recently just really understanding the importance of advocacy. And advocacy can take many forms, right? Or several forms. And for me, the two that have really jumped out recently are personal advocacy, but really probably more central to this conversation is community advocacy. But all of us can be an advocate. And so for me, using the personal advocacy example, that's actually how I became a doula. Based on my lived experience of my 2 pregnancies, I was like, there's something else that needs to be done to help Black women during the birthing journeys. I think I would like to become a doula. So that's been my personal advocacy for the past 4 years. But community advocacy is so impactful. Again, where you live locally, part of advocacy, is this type of conversation that we're having. So let's take it off the screen, have it in your communities where you are, and what are the solutions where you are. We don't have to wait on systems, funders. Yes, we do need money and all those things, but we can start to, have the conversations right in our community, and it can grow, scale out. We apply together for funding X, Y, and Z. So I just encourage all of us to figure out what community advocacy means for you in your local community to address whether it is expanding, postpartum care, access to care, or whatever the issue is that is central to you. And lastly, because I am a member of a nonprofit, I'm always going to plug that people donate to nonprofits that are doing the work that you feel passionate about.
Thank you. Nikitra? Dr. Burst?
Yes, so my vision for now and the future is always that Black women have the birth that we deserve and desire, and postpartum. And so whatever it takes for all of us to work together doing that, whether that's funding, whether that's primary care direct services, and even voting, I think we all have the responsibility from where we sit in this ecosystem to do our part to get realize that vision.
Thank you. And to close this out, Dr. Gillespie Bell.
Yes, I have a quote that I think really it encompasses what everybody else has said, but it's a quote that I commonly end with when I do lectures on health equity, and I think is applicable to now. It's from Dr. Martin Luther King Jr., and it says that the ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge and controversy. And I would say that, at least for me, in medicine, this is the most challenging and controversial time I have ever practiced in. I never thought I would be practicing and fearful of going to jail for practicing medicine. And I think all of us have different challenges to, as Tanisha was saying, to our reproductive rights, to bodily autonomy. It's a very challenging time, and it's a controversial time. And we have the option to sit and say nothing. But if you sit and say nothing, you're still saying something. It says you're okay with the status quo. So everybody that is listening, everybody that you talk, you touch, you can touch, everybody has something to do and to say to improve our maternal outcomes and to improve the systems that are not designed for us to not only survive, but to thrive.
Thank you all so much. Thank you for the audience, and thank you to our panelists. Over to you, Janelle.
Once again, thank you for joining us for today's discussion. I hope we have left you with some important insights on how we can all contribute to a more robust ecosystem of care and the role of the reproductive justice movement is playing in getting us to the vision. We hope you will join us for our next conversation on economic mobility on November 19th. Please take a moment to complete our brief survey after the webinar ends. Here you can opt in for more information about future webinars. I hope you all have a beautiful day and keep on fighting.
Thank you.